Hey, good morning, everyone. Thank you for joining us for the morning session, day 2 of the AHI Leadership Summit. We're going to let people give them a few minutes to get into the meeting, and then we'll get started. We've got a good crowd for your presentation this morning, Cassandra and Jackie.
Good.
Yeah, a little over 80 people registered, and we're seeing anywhere from 60 to 50% of that coming. So we are going to be emailing out the recording and slides after, or we're going to upload them on our website. All right, good morning, everyone, to day 2 of the AHI Leadership Summit morning session. We're going to give about 2 more minutes to allow people to get into the room, and then we'll get started. Right, good morning. If you're just joining us, we're going to give a few more minutes to let people get into the room, and then we'll get started. Okay, let's get started. Good morning, everyone. Thank you for joining us for day 2 of the AHI Leadership Summit for our morning session. This is our 12th annual summit and our first ever virtual summit. This morning's presenters are bringing you Engaging Community Partners for Whole Person Care. It's presented by Cassandra Becker of Uplift Warren, Washington County, and Jackie Foster of the Baywood Center, 820. Jackie, it's 820. I want to make sure I say that right. 820 River Street, okay.
Yep.
My name is Courtney Shaler. I manage the Adirondack Rural Health Network for AHI. I'm proud to welcome you this morning on behalf of our CEO, Eric Burton, our AHI Board of Directors, and the staff here at AHI. We're going to take a minute to say thank you for all the sponsors who have made this event possible over the last 12 years. We are very appreciative of these business partners, and we look forward to hopefully being in Lake Placid in person next year so that you can chat with them in our vendor hall. I'm going to go over a few summit best practice tips. Please confirm that you're muted and your video is off upon entry. To avoid audio issues, please choose their computer audio or phone audio. Using both may result in an echo on your line. For optimal viewing today, we recommend you use side-by-side mode. To activate side-by-side mode, go to the view options at the top center of your screen and choose side-by-side mode from the drop-down. You then can hit speaker view, and then you can see the video of the presenter and the slides at the same time. We encourage you to use the chat freely to submit all questions, technical issues, and any comments you may have for our presenters. AHI staff will be monitoring that, and we'll make sure all your questions are answered. The presenters will present this morning for about 45 minutes, and then we'll leave 15 minutes for questions. If we get more questions than we can possibly answer, we'll make sure to connect you with our presenters after the event. And last but not least, all presentations will be archived on the AHI Conference's website by October 9th, not only the slides, but also the videos as well. Now I'm going to turn screen sharing over to Jackie and Cassandra. Excellent, Jackie. I can see your screen.
Okay, there we go.
Okay. Perfect.
All right, perfect. Good morning. My name is Jackie Foster. I am currently the Director of Outpatient Services for 820 River Street. We operate residential and outpatient facilities. Currently, I oversee the 2 outpatient facilities in Queensbury and Albany. We do intensive and non-intensive treatment with our clients. And most recently, I've started spending a lot of time in the community. When I first took on the position of a program director, I spent a lot of time with clients. Prior to that, I spent a lot of time in clinical care, treating each individual at a time. And then there became a big shift for me where I moved more towards community population care, and looking at more how can we help people as a whole versus how can I help an individual. So that's a little bit about what we'll talk about today. But as far as, you know, my experience goes, I went from, you know, treating the individual to, you know, looking at a population of people on a much larger scale and saying, how can we help? So I'm going to turn it over to Rebecca, or sorry, not Rebecca, Cassandra, to introduce herself.
Good morning. I'm Cassandra Becker, and I am the program coordinator of the Uplift program. Uplift was a Adirondack Health Institute Disrupt Initiative project that was created to address the transportation needs and the barrier that that created for the individuals in our rural Warren, Washington region. So I came on board to kind of basically help create this program and to oversee things as we kind of picked up speed and have been kind of working now for about a year.
Thanks, Cassandra. So one of the things that I wanted to make sure that we're kind of all on the same page in this presentation today is understanding what is whole person care. I feel like it's a topic that gets thrown around a lot, a term that gets said a lot, but you know, when we're looking at it, you know, in terms of the presentation today, I found this definition that I wanted to, you know, just put out there and use because I think it's a really good definition, and I have it quoted here. Whole person care can be defined as the coordination of health, behavioral health, and social services in a patient-centered manner with the goals of improved health outcomes and more efficient and effective use of resources. So for that, you know, putting it more into a, you know, everyday working thing, what we do is we recognize that the best work we can do with a patient is to involve all sources of the community into their care that'll give them a much better outcome. And recognizing that if we treat just one thing within a person, that we're really going to be lacking in getting that person to move forward because they're going to be stuck in other areas of their life. And the other big, you know, thing I just want to get out there today, and I work with my clinicians all the time on this, is recognizing that when we work together, we do much better job than when one person works with one person. So kind of looking at this last little bullet I have down here stating that recognizing that you cannot help a client alone. And that has nothing to do with the effectiveness of anyone as a counselor or a therapist. It just has to do with the fact that a person has so many layers to what's going on with them. And as one individual, we can't fix everything for them. So when we go, you know, as an agency, looking at it from a larger scale, when you start to think about, okay, how do I treat someone? How do I, you know, get into this whole person care? How do I develop relationships? You start to work together with your team and start to ask yourself some questions, and identifying what is it that my community needs. So in thinking about kind of what our process looked like, I thought back to think, okay, what did we do? Where did we start? And the very first things we started doing when we wanted to get into a more broader treatment scale was we started to attend community meetings and figuring out in those community meetings, where are the gaps in services for the population that we serve? Is there another population that we don't serve that we could be helpful to? And we started just asking questions and listening. And we then also started to attend forums in the community. And we started to listen to the community and listening to what they needed and what they wanted. And really starting to gain an understanding of what is it that the community feels they need, not what is it that I feel they need sitting in an office every day, coming up with great ideas. We looked at research data. What is it that people, you know, who sit there and do research all day, what are they getting out of their studies? We asked caseworkers, we asked therapists, we asked doctors, we really started to reach out and ask the people on the front lines, what is it that your patients need? And then we also started working with the county and the state, you know, on a much larger scale to say, okay, how can we reach out from just this, you know, small outpatient clinic that treats about 200 clients at a time to how do we become a much larger scale, you know, unit to help all of those 200 clients that we have engaged in our care. So that, you know, that's kind of where we started. And from there, we then started to take a look at some pretty specific questions. And we'll go through those a little bit more, but you know, looking at the slide, we asked how can our agency help? We treat substance abuse clients. So obviously, you know, if someone needs physical care, that's not something we can help with. So we really wanted to make sure we were staying in our lanes. We were still doing the work that we needed to do and we were qualified to do, but looking at it at a larger scale of, you know, maybe there are other ways that we can help and still do our work, but in different areas. We started to ask, can we tackle this on our own? Or do we need other people to join with us to be able to reach this goal? We began looking at how partnering would improve the overall health of the client. So I'm not gonna lie, there's times where, you know, it seems like it's this big task, and then you get this person in front of you who's a real person, and you start to understand, this is why I do it. This is why it's important. So you have to keep that in mind, because it's a task. It definitely is when you're getting a lot of different people and a lot of organizations together, but keeping in mind that you're helping the overall health of the client. We had to look at the financial impact. You know, financially, could we take these things on? And that's a huge part. I mean, ideas are great, partnerships are great, but if they're not financially sustainable, you're not going to be able to continue to do the work that you do. So really looking up front to say, financially, can we take this on? And sometimes the answer to that is no, financially we can't. And that's okay, but you don't have to squash your ideas right there. You can go and look for grants or other financial assistance, which is, you know, in some of our programs, what we had to do, because the answer was no. We're not gonna make money off of this, but we were able to find grants and, you know, other ways of paying for it that made it possible for us. So when we started to work with the community and engaging community partners, there was a couple of steps that I think were really important in building those relationships and those partnerships. And one of the first things that we did with that partner was to sit down and look at, what are the shared benefits by us working together? A partnership is not going to work well when only one person or one entity is benefiting from it. So we really had to make sure that when we were working together, that there was going to be a mutual benefit and a clear understanding of what that benefit was for each of us. We had to identify, what is the goal? And what we found sometimes is that when we were sitting down with a partner, the goal wasn't always clear. They do something different than what we do. So our version of the goal was different than what their version of the goal was. So we had to come to an understanding of what is a common goal between us to make this partnership work. And then also discussing, do we need to bring additional people in? You know, as I said in my second slide, we don't do this alone. So, you know, it goes to say as well that sometimes just two entities can't reach an entire goal by themselves. So we had to look into the community and say, are there other valuable partners out there that we can bring into this to really make this work? And you really have to be willing to work with your competitors. You have to be willing to work with, you know, agencies that you may have never worked with before. and keeping that open line of communication with them, because that's what, prior to creating this whole person care, we were really good at staying in our own little bubbles. And so venturing outside of those is what the change is, and change is hard. And, so building those relationships is hard sometimes, and getting everyone on the same page is hard sometimes, but it's really so important, if you're going to really treat the person as a whole person, to get rid of those bubbles and just step outside and make new relationships and partnerships. And when building those partnerships, it's really important that you communicate what your expectations are. I've been in many partner meetings where I walk in with, okay, this is the expectation of this meeting, and then I walk out feeling like, gee, I don't know, did we even do what I thought we were here to do today? So it's really important, as you start those relationships, that you communicate what are your expectations, and then come to a mutual understanding of what those expectations are. And once you do that, you can start to identify, who's responsible for what in this partnership. And how will we discuss with each other when we feel someone's not doing what their responsibility is? How will we track the success of this partnership? How will we talk to each other? And then being prepared to come to the table and rework out plans, because there's been plenty of times where we've come up with a plan and then you start to execute it and you realize this isn't working, or we have to tweak this. And so if I can say anything in terms of really building those partnerships, is being willing to have difficult conversations with your partner about, I think we're messing this up, or I think, we're going in the wrong direction, and really, standing up for what your belief is in that partnership, because you really need to be able to communicate and to build that good partnership with each other. So I wanted to give you a couple examples of programs that we've utilized those same strategies with, to be able to build some pretty successful partnerships in our community. These programs all run out of Warren and Washington County, which is, kind of considered upstate New York. It's above, Albany, Saratoga County. So those are the two counties that we kind of encompass in our community. So the three programs that we're highlighting today are our ABLE program, and ABLE stands for Alternatives to a Better Living Environment. And we'll talk a little bit more about that. We run a community health and wellness program with the YMCA. And as Cassandra mentioned earlier, she runs a program called Uplift, which is a transportation program that we've worked together with the community to arrange. So the goal of ABLE, as I mentioned before, it's a program that helps transition inmates or people who are at risk of incarceration back into the community. So when we sat down with our partners, we had to identify what is that goal. So when you come up with one common goal, that's really helpful. So the goal that we came up with was to help inmates or those at risk of incarceration connect to services as soon as possible to provide the best transitional services. So that's a very clear cut goal. It's easy for all of our partners to understand, what are we doing here? And to be able to make this possible, we had to partner with the Baywood Center, which provides our substance abuse services, Warren County Jail, Washington County Jail. So those, obviously were where the inmates were incarcerated. We partnered with the Office of Community Services as well, and then the Warren and Washington Association for Mental Health. We really wanted to make sure that we could treat dually diagnosed inmates, understanding that many, people do not end up in jail because they are healthy individuals mentally. So we, recognized that we needed to bring in an agency that was well equipped to deal with all sorts of mental illness in order for this to be successful for us. So in the ABLE program, the jail coordinator, which is operated out of the Baywood Center, meets with the inmate that's referred either by jail, probation, courts, lawyers, family members, to identify what unmet needs that person may have. And then they coordinate those services so that they'll be available upon release for that person. And, the outcome is that we would want to see them transition quickly into these services so that they remain out of jail and don't go back into the cycle of incarceration and legal issues. But we know that they can't successfully stay out of incarceration without dealing with their social determinants of health. So our jail transition coordinator really looks at, what do I have to do to make sure that they have the best living environment to help prevent them from getting back into this cycle. So in order for her to do that, she has to coordinate with the community agencies that service the different areas that that person may need. So we coordinate with the Department of Social Services in both counties. We partner with long-term case management services. So we consider ourselves very short-term in this person's life, but we know that some of these people need much longer term support services. So we really make sure that they're set up with long-term case management services once we step out. We spend, usually under 90 days with the person. So we make sure that they have a longer term option for them. Mental health services, substance abuse services, legal aid, legal entities, food pantries, employment assistance programs, housing and shelter, and transportation. So as you can see in here, we really have to work with the community to get this person to be able to reach this ultimate goal that we've identified up at the top of this slide. And in a lot of ways, we're able to coordinate with some of the other programs that we run. So a lot of our programs have a dual benefit to us. You see on here transportation. We refer to Uplift all the time for the transportation. In terms of healthy activities, we refer to the YMCA program to get them back engaged in healthy activities and someplace to bring their families. So a lot of our programs work together as well. So I wanted to give you an example of, kind of how this plays out. I said in the very beginning, I've moved my focus a lot to this idea of population care. However, that population care work impacts an individual person. So I wanted to just give an example. And I obviously used like a fake name. We'll call him Joe. But prior to getting involved in the ABLE program, Joe was in and out of jail, multiple incarcerations, both in the county and in the state. When we got involved with him, he's quoted by the case manager stating that if this doesn't work, I'm just going to go back to selling drugs. He was very hopeless in his life. He didn't, see any other way of making ends meet for himself. He had no housing options when he got out of incarceration. He had no social supports. Most of, his social supports were out there doing, negative things as well. So he didn't want to re-engage with them. He had pending charges in another county and no insurance. So when our jail transition coordinator became involved with him, he actually had about 6 months before he was going to be released. So she may see someone, in this case, like 6 months prior to them being released, all the way up to they're being released tomorrow, and she has to work very quickly to get some of these services engaged for them. So in this case, she did have more long-term to be able to do that. But what she did is she went in and she did an assessment of what he needed, and found that she could get him involved with a insurance navigator to have insurance when he got out. We all know how important that is. She connected him to Uplift for transportation. She worked with the other county and those legal representatives to resolve the charges that he had in the other county. She worked on getting him medicated assisted treatment for when he was discharged. She had to go over to DSS and really work with DSS, and we had already really set up a good relationship with Department of Social Services to understand that a lot of these people that we're working with have sanctions. So by joining into the ABLE program, we knew that we could work with DSS to get those sanctions removed, and be able to offer them more services when they get out. So she was able to do that. And then also get him personal care items through Community Action, which is an agency that, you know, provides items and food and things like that to people in need. So when he got out, you know, he was able to have a place to live. He had personal need items, he had insurance, he had substance abuse service set up, he had his mental health services set up, he had his primary care doctor set up. So we had everything to really encompass this gentleman to be able to help him be successful as long as he engaged in these services. So now, you know, Joe, he did have to go to inpatient. You know, not all of these come out and they do perfectly. So we worked with him over the 60-day time window to make sure that they're engaging in these services. And we did get him to go inpatient. We found housing for him. We engaged him with a CERPA, which is a Certified Recovery Peer Advocate for support. She was able to get him back into the recovery community. She got him into support meetings, into our community recovery services, and he actually engaged in and found new friends. And the biggest thing for us, which goes back to that original goal that we had, was he's not back in jail. I'm not saying that this man's life is perfect. We still know Joe. You know, he still messes up from time to time, but he's not back in jail. And he's really engaged in these services that we set up for him about 8 months ago at this point. So we feel like Joe is a perfect example of what working with the community can do for a person. Because if you look at him from before, it was just a constant cycle of going to jail, getting out of jail, going to jail, getting out of jail. And the fact that, you know, we're going on close to a year now at this point, and he's not back in jail is huge for us. So moving on to our next program that we wanted to highlight, and that's our Community Health and Wellness Program. So kind of going on the same outline, our goal for that was to improve mental, social, and physical fitness for the individuals that we serve. And to do that, we had to partner with the Baywood Center, the YMCA of the Greater Glens Falls area, Council for Prevention, and the Alliance for Positive Health. The program works with participants participants work together with a CERPA and wellness coordinator to identify how to utilize the YMCA to improve not only their physical health, but also their emotional, mental, and social health. So with this program, we really started to look at the fact that, okay, how do we pull physical fitness into this whole person care? How do we pull social fitness into this? So we worked together with the partners mentioned above and really asked those questions in the previous slides of how can we do this? And it took a lot of meetings, but we ended up figuring it out. And this was one of the programs that we really had to go back and forth on that drawing board and saying, this is working, this isn't working. And being able to really communicate with each other openly about what each partner was doing that was helpful and not helpful to the program. So currently we've been running this program for about a year and a half. So how we really address that whole person care is, as far as the social aspect, we worked together to be able to run group activities geared towards wellness participants. So we would run a monthly activity. It could be volleyball, it could be a softball tournament, it could be apple picking, but it was a social activity that would involve the wellness participants, and it was free of charge to them to be able to go and to engage in something that was healthy and social and be around other people, while also, you know, working with us on staying sober. We knew that a huge barrier to treatment was childcare. And so we worked with the YMCA to say, how can you help us with this? And what they identified was they have childcare services. So if we had a person who was in treatment, the child could go to the YMCA for the help, or for the, while the person was in treatment, or they could, if they were working out, the child could also engage in the childcare services. We had, you know, children that engaged in summer camps, in the preschool that's at the YMCA. So, you know, we looked at, not only is it whole person care, but it's whole family care. And oftentimes people's barriers are related to their family, not just themselves. We looked at, okay, how do we help them physically? So we monitored things like their BMI, their blood pressure, their body fat. And we, you know, we really encouraged anytime that we saw progress in those areas. We had trainers that, you know, worked through the Y that were really good at, you know, understanding body composition, and okay, you might not have lost any weight, but you've lost, you know, X amount of inches, or you've gained this muscle mass. So we really targeted that physical side of their recovery and their health. We looked at how do we emotionally wrap around and support them. And what we found was we employed basically two different roles in the program. And what we had a wellness coordinator who was an employee of the YMCA, who was specifically targeted to this program. And then we had a certified peer recovery advocate as well that was dedicated to the program. And they were able to meet with the participants and talk to them and provide that emotional support. And we had, you know, times where you would think that the conversation started off about how was their weekend or how was their workout, and then the next thing you know, they're talking about their, you know, romantic relationship and the problems they're having there. And so it really opened up that line of communication to allow some emotional support as well. We looked at nutritional support. How do we support them nutritionally? And then also some case management support. So it's, you know, great to be able, for a person to be able to talk about what's going on in their life and what they need, but sometimes they don't understand how to make those connections, how to take that next step. So having the SERPA available to them allowed them to be able to help them take that next step to really be able to improve their overall health and wellness. So kind of like the ABLE program, I wanted to give you a real life example of a person who we engaged in this program. We'll call her Jane. So prior to coming to us, Jane was homeless. She was living in her car. She actually came from a different state to get away from an abusive relationship, and she ended up in New York somehow, homeless, living in her car with her son. CPS became involved because she was not providing adequate housing for her child, and she was an active user, so she was addicted, and she didn't know anyone from around here. She had no services as far as DSS goes. As I mentioned, she was new to the state, so she didn't know how to navigate the New York State systems. And she was also a diabetic, and she, was untreated for that at the time. She had no insurance. She had no primary care doctors, none of that. So she ended up getting referred to us because of her involvement with CPS. So we utilized another program that's not highlighted in here, but we have a community outreach program, which meets clients out in the community. And because she had such limited resources, we felt like it would be a really good program for her to utilize. So our outreach program went out and started meeting with her, got her engaged in treatment with us, intensive treatment, was able to get her, sober, and she remained in her car for a little while. While she engaged in getting some DSS services, we helped her do that. But specifically to the YMCA, this woman went there to shower. So when we talk about health and wellness, we're not just talking about what is their weight, what is their BMI. We're talking about, for this woman, some very simple hygiene needs of showering. So her and her son would go there. He would do childcare there. He would do camps. They would work out as a family. His foster care worker would bring him to the YMCA. It was a safe environment for them to socialize in. And then she would utilize the other areas to be able to, provide some basic hygiene for herself, so she could feel better about herself in those respects. We, as mentioned before, we did coordinate DSS services for her. So we got her housing, financial assistance, we got her insurance, we got her hooked up to a primary care doctor. And with this particular, she required a lot of care coordination. She had multiple entities involved with her case. So we engaged in care coordination meetings for her. So now Jane is she's doing wonderful. She's sober. She has her own apartment. Foster care has returned her son to her care. She's sober. She has worked with our SERPA and found community support groups. She receives enough DSS benefits for her to independently live and raise her son. And as mentioned before, she is a diabetic, and she is now medication compliant with all her diabetes medications and has not been hospitalized for her diabetes at all. So, we look at so many different aspects when it comes to Jane. And if, I go back to thinking, if we had just gotten her sober, I don't know if that would have ever been enough for her. I don't know if she would have been able to get all these other services engaged for her. So I'm not sure where she would be if it wasn't for really looking at what does this woman need overall, and not how do we just get her sober. So I'm going to hand it over to Cassandra so she can talk a little bit about Uplift and how that program has also done a lot of the same things.
Good morning. I'm Cassandra Becker, and I'm the transportation coordinator for the Uplift program. Uplift is a program that is intended to work with people who are transitioning through an issue with their health. Initially, when we first started, we were working with people on a 30-day hospitalization readmission prevention. However, we determined quickly that working with people that only had been in the hospital was basically kind of already defeating the purpose of preventing the hospitalization. So we looked at preventing the hospitalization entirely. We provide community access to individuals to attend medical appointments that aren't covered by Medicaid, community support programs and counseling programs, DSS appointments, court appointments, to go to the food pantry or the grocery store, and we will allow them to pick up medical equipment or pharmacy needs so they can go and pick up their medications. Our goal is to promote preventive health by giving individuals increased access to care services by relieving the hardship of the lack of transportation. Our counties, Warren and Washington, are a fairly rural county. There are some public service transportation modes. However, they can be fairly costly for individuals who are utilizing them on a daily basis, especially when you compound the issue with medical costs. So we worked with Baywood, United Way, Greater Glens Falls Transit, Warren Washington County Association for Mental Health, Hudson Headwaters, Glens Falls Hospital, the Center for Recovery, Washington and Warren County DSS, and other various little agencies within our Warren, Washington, and Northern Saratoga County region. We created a program that would allow individuals to stabilize their condition and prevent hospitalizations or ER visits by giving them access to these things. Uplift is a fairly simple program. I was a care manager myself for years, and I know oftentimes that individuals will get paperwork fatigue. So we created a simple single-page voucher request form for these individuals. So then that way we're able to get all the information that we need, but also allow the individual to not feel this overwhelming application process, which has been extremely successful. Our community engagement and outreach, simply by attending the meetings like Jackie said, or doing the boots on the grounds and stopping into agencies and taking that 10 minutes to just kind of explain what Uplift is, and accessing us through phone calls and emails, and kind of always being there and willing to kind of discuss a case as to how we can help an individual meet their needs, has really allowed for a considerable amount of change for our region. Uplift at this point has given just shy of 3,000 vouchers in our 1.5-year time frame. We utilize our bus system, we utilize taxi cabs, we can provide gas cards to individuals who need them for appointments, and we can also work with them to kind of determine which mode of transportation would be best to kind of meet those needs, and then do that soft handoff to other agencies that can kind of help collaborate that whole person care. I'm not dealing with a lot of things myself, but as a care manager from the region in the past, I'm able to kind of understand who's where and what might be the best avenue to kind of connect that person. So then that way their needs can be met overall. Jackie, do you want to go to my next slide? That's back to
all on one.
That's all back to me, or that's all back to Jackie then. If you guys have any questions as far as Uplift, please feel free to send them in the chat box, and I really appreciate the opportunity to speak about our program.
Thanks, Cassandra.
Thank you, Jackie.
So, as mentioned a little bit earlier, that building these programs together doesn't come easily. And I don't want to, sit here and talk about all the negatives for too long, but I did just want to point out some challenges to the whole person care, because I think that the challenges also offer an ability to come up with solutions and possible, things that'll help in the future. So some of the challenges that we ran into were finding the common purpose for all parties. As I mentioned earlier, we don't all have the same goal. We don't all service the same people. So kind of coming together and finding where is our common ground and what is this one common goal that we can all work on. So in that same respect, I found that as far as communication goes, one of the biggest things I've learned is that we don't all communicate the same way. And in our fields, we have different languages almost. We have different terms, or the same terms that mean different things. So, we really had to ask questions and identify, what do you mean by that? Because when I say this, I mean this. We had to work through workflow issues. Anytime you enter into a new partnership or you start a new program, there's workflow issues that you have to work through. Oversight agencies. So our oversight agency is OASIS, where Warren and Washington Association for Mental Health is Office of Mental Health. So we have to work through what are the different oversight agencies and regulations that each of us have to follow. Funding streams. So I don't think I have to go on with that, but sometimes funding is not the easiest thing to come by. So you have these great ideas, but the question is, okay, well, how are we going to fund these? The silo care, earlier I referred to them as bubbles. But if you kind of look at the graphic I have provided here, I would say 5-6 years ago, that's how we were offering care. We at Baywood Center, we would focus on, okay, are they sober? Great. We weren't really looking at, do they have a primary care? You know, do they have access to food and water and shelter? And so we've really, you know, been able to change that mindset over the last couple of years and really focus on, do they have everything they need in their life? So, I mean, another thing that you've got to look into is client buy-in. None of these programs would be possible if the clients don't see the value in it. And we'll talk a little bit about that in a minute. Technology's been an issue at times. Data sharing, that's, you know, really been an area that's been a huge struggle for some of us. As you reach into other industries, other agencies, sharing their data is not always something that they're willing to do. And then understanding the improved health if we break down these barriers and silos. So this slide, just real quickly, why try? I found this infographic, and if you look at it, it really just talks about why we should try to do this, because there's currently about 34 million Americans who have a comorbid mental health and medical condition. So that's a lot of our patients, and we service them across a lot of different industries. And if you look at the infographic, you're looking at, just for ours, like if you stick to addiction treatment, there's 148% more successful treatment if we engage them in these other areas. And you'll see there's a reduction in depression. There's an increase in them going to their primary care and engaging in physicals annually, which we all know how important that is. And on a financial end, there's a decrease in the cost of care for that person, a decrease in hospital admissions. So it's important to try. So continuing on the why try. So that infographic, I feel like, was a much larger view, but if you really want, if we take it down to a very individualized view, the positives that we've found is there's a much greater staff satisfaction. When a therapist can know where to refer someone and how to refer them and know that they're going to get the care that they need, that counselor can rest easy. And there's less burnout on that staff member's part, less staff turnover on our agency's part. So it is important to put in that work initially, because you're going to help your staff and you're going to help the individual. When it comes to building your VBP contracts, you're going to be able to have, you know, better outcomes and build, you know, in a good insurance contract. In addition to this, the financial end, you're going to be able to have a program or a product to show to get additional funding, grants, get, you know, different ways to reallocate money coming your way. Earlier I said we'll talk a little bit more about clients. And what we found is that we were really able to reduce those barriers for clients. And so they were more eager to engage. It wasn't as hard to get them to commit to something. And then healthy can be contagious. And that's really what we found with the YMCA program, especially, is that when other clients saw clients going to the YMCA and engaging in healthy activities, they wanted to go too. So we really utilize them as our posters, you know, go see what so-and-so is doing and how great it is. And then a longer lasting change for them in their health. As I mentioned earlier, it's not like we've, you know, changed everyone's life forever, but we've helped them make some healthy choices that'll hopefully help them continue in a healthy direction. And the last, you know, point I want to make here is that we all live in this community. These are our neighbors. These are our community members. So the healthier they are, the healthier our community is. And the more success we have in ending some of these cycles that we know happen around us, okay. So I believe we are right on time as far as wrapping up. Here are our contact information. My name is Jackie Foster, once again. And then Cassandra Becker's information is here as well.
Hi, thank you so much. That was wonderful, Jackie. We did get some questions, so I want to make sure we can get through as many as we can.
Okay.
Okay. Let's see. There was a couple questions about ABLE and some questions about Uplift, so I'm going to start with the first one about ABLE. Susan wanted to know, and I know that isn't your program, but you do work with them, so perhaps you can answer this, Jackie. Susan asked, is the inmate required to meet with the coordinator if referred?
Or they all meet with them. So it's a voluntary program. I'm not exactly sure what the question's asking, but it's voluntary on the inmate's part. They're offered it upon coming in through medical. And then as they work with the social worker, again, they're offered it. So we found that when we originally thought, oh, great, we'll screen them right as they come in and we'll get them all there, we actually found that most of them were angry and like said no.
Okay.
And the best way to actually get to them was once they were settled in and we had the social worker engage with them and talk about the program with them, and then the social worker would refer them over to us. So I'm not sure if the question was asking about if it's mandatory or voluntary, but it is voluntary on the inmate's part. We made that very clear. We didn't want to make this, something where they had to engage with us. But if they wanted to, we're there.
Excellent. Thank you, Jackie. I think that did answer the question. I
Okay.
feel. Okay, Cassandra, and I know you kind of touched on this a little bit, but perhaps you could just touch on it again. Where is the funding coming that provides the vouchers for Uplift?
So Uplift is funded through a district grant. We are actually in the process of looking for continued funding. So if you know of any grants that might be applicable towards, continuing our transportation program, please feel free to send them my way. As of right now, we're guaranteed funding through the end of this year.
Okay. Absolutely. One of the roles of the Rural Health Network is to increase the funding for population health initiatives. So we'll keep an eye out for you, and I'm sure other people in the room will too. Jackie, this one's for you. You mentioned DSS sanctions and how if people come in the program, those get removed. Can you kind of explain what? I don't think everyone in the room is quite familiar with the DSS sanctions and what that meant.
Okay, so yeah, sure. So when someone engages in DSS services, there's requirements that they have to meet in order for them to continue to engage in funding. So the most common one that we ran into was that someone who had substance abuse issues would apply for services and they would be required to engage in a certain level of care, and they wouldn't. So what DSS does is they place a sanction on them saying they can't receive any services because they didn't follow our guidelines previously. So we actually went straight up to the commissioner of DSS to talk about this and how much of a barrier it was for us to be able to make some real changes in these people's lives as they get out of incarceration. And she was more than helpful. And basically, through that coordination, she said, just come over, let us know what's going on, and we'll remove those sanctions. So all it took was a meeting. But it made a huge impact.
That really speaks, Jackie, to cross-sector collaboration, which we all talk about a lot, so props to you guys for making that happen. There's another question here. How does 820 River Street use technology to coordinate whole person care? Do you use some sort of social determinants of health tech vendor? If so, what has your experience been?
So we do use the social determinants of health. It's built into our electronic charting, which is 1011. And then, we also, if you're talking about technology, without getting too specific into the program, but what we've done is we've created each program in the electronic charting system as a separate program. And then that allows us to pull data and information off of the electronic charting system for reporting and things like that. And then as far as other technology, we're now utilizing a lot of telehealth to help with these programs as well.
Excellent. Thank you, Jackie. I just want to remind everyone we have a few more minutes, so if you have a question, please ask now, and to let everyone know that we are archiving both the recording of this session and the slides, and they'll be up on the AHI Conferences site on October 9th. I have a couple comments from Rebecca. She wanted to let you know she's grateful for the Uplift program as it has helped many of my clients. It's also quick and easy to process whenever I want to refer a client. And then also this one from Susan. Thank you. Grateful to see these system changes for our community members. I make many connections to these programs as the New York Connects coordinator for Warren County. So a lot of love in the chat here for y'all. And then there's one more question. Do you use HCSCN services to view patient records?
We are trying to get involved with HCSCN. We're having a hard time with that. That's one of those challenges. But we do utilize psyches, and we utilize AHI to provide some of the information. So when we can't get the information ourselves, we have business agreements and things like that that allow us to go to some of our other providers and say, hey, can you access this information for us?
Okay, excellent. Thank you. Jackie, Cassandra, do either one of you have some closing thoughts that you'd like to leave the group with?
The only thing I would put out there is, as you guys listen to these programs, if you're in our communities and you think that you can help, increase the amount of services or what we can do for clients, reach out to us. I mean, just because we have these programs existing doesn't mean that we couldn't find ways to build in more services and partner with more people. We know that our job isn't done. We know that there's still way more work we can do. So if you guys have any ideas, please reach out to me. And we're more than happy to engage in partnerships across more sectors.
Okay. And great, Jackie, I'd love to invite you to an Adirondack Rural Health Network meeting too, to collaborate with those partners. So we're going to add you to our Outlook list, and Cassandra is already a member of the network too. So Cassandra, did you have a few closing thoughts for the group?
Obviously, if you have any questions or needs in regards to Uplift, please feel free to reach out, as Jackie had said. And, the creation and kind of development of Uplift really was something that was built around the collaboration of individuals within our community and what our experiences have been as care managers together. So if anyone has any ideas, please feel free to throw them out. I'm always looking for increased development, things that'll make things go smoother, and just meeting the needs of our individuals much better than currently we are.
Okay. Thank you, Cassandra. Thank you, Jackie. I also wanted to let you know, Jackie, that Tessa works at HCSCN, and she would like to connect with you after to help you get your issue with HCSCN addressed. So Sarah and I will connect you with her after. Okay?
Thank you.
Thank you both so much for joining us today. We really appreciate it. And hopefully you'll join us this afternoon at 2 p.m. for our afternoon session. Thank you.